good morning, everyone. My name is Chris Brusalis. I'm a sports medicine and shoulder surgeon at the Hospital for Special Surgery. And let me just start out by first, we're doing this webinar right after the lacrosse season finished up. So congratulations to all of the New York State athletes who participated in that tournament that was very successful over this past weekend. Today, we have something special in store. We are going to essentially go through all of the different potential injuries throughout the body. It's kind of a whirlwind tour from head to toe, shoulder down to the foot, injuries that can happen in high school athletes especially. And so I'm going to start us off talking about the knee and shoulder, and then we're going to have a few other lectures talking about different areas, different anatomic areas. So it should be a pretty comprehensive talk on topics that are really relevant to high school athletes. So for the next, 10 minutes or so, I'm going to focus on injuries of the knee and shoulder. And rather than bombard you with a ton of conditions, obviously there's a lot of different injuries that can happen in both the knee and the shoulder. I really want to focus on two particular injuries so we can delve into a little bit of greater depth. And so for the knee, we'll start talking about ACL prevention, what an ACL injury is and how to prevent it, both on an individual and on a league level. Then we'll talk about treatment of a different condition in the shoulder, and that's related to shoulder instability or shoulder dislocation. These two topics are picked both because they're extremely prevalent and also because they're relevant for our high school level athletes. So let's kick it off first with discussing the topic of ACL prevention. And so for those who haven't seen an ACL injury before, let's see if this plays. I want to show you just how an ACL injury can happen. And so this is a NFL game from several years ago where one of the defensive players celebrates sacking Tom Brady, but then in his celebration, he sustains an ACL injury. And so, most of these injuries occur during the game, but this is kind of a unique example of someone who, after the whistle was blown. So you could argue that maybe the best thing we could do as coaches and trainers is just to tell patients or tell athletes how to celebrate. So this is clearly an example of how not to celebrate. So let's jump into ACL injury. So there are quite a number of ACL injuries. It's one of the most common injuries that we see as sports medicine surgeons. There are about 200,000 ACL injuries each year. They primarily affect athletes who perform cutting and pivoting sports, lacrosse being a huge example of that. While we are, as surgeons, spend a lot of our time improving our techniques, improving our surgical skills, and the devices we use to perform ACL reconstruction surgery, nonetheless, it still takes approximately 1 year to recover. And as good as we are, as we think we are about fixing these ACLs and getting patients back to sports, the data says that about 81% of athletes return to sport and only 55% of them play competitively after recovering from an ACL reconstruction. Not only that, there are long-term consequences to the knee, whether or not a patient undergoes ACL reconstruction surgery, whether or not they return to play. There's some data that says that 80% of patients who undergo ACL reconstruction develop arthritis 15 years later. So, as much as we focus as surgeons on fixing these problems, it's very important that we also spend a commensurate amount of time learning and working on strategies to prevent them from happening in the first place. So understanding the mechanism of ACL injury provides an important baseline to establish effective prevention strategies that minimize these risk factors. So how does an ACL injury happen? Well, we just saw a video of it. There's a couple of different components that can happen in isolation or in combination. So one is a rapid change of direction during deceleration. So a player's on the field and they perform a quick pivoting movement that predisposes someone to an ACL injury. Stopping abruptly, and just like we saw in that video, landing from a jump. So all of those factors can potentially lead to an ACL injury. So what are the risk factors for ACL injury? This is also important when trying to figure out ways to prevent it. We have to identify athletes that are particularly at risk. So we categorize risk factors into non-modifiable and modifiable. So the ones that we really don't have much control over is that female athletes have a higher predilection for sustaining an ACL injury, younger aged athletes under the age of 20, poor weather conditions during outdoor sports, So, on a rainy day or after a little bit of rain, that's certainly going to make the conditions a little bit more susceptible for an ACL injury. History of prior knee injury. So, arguably you could potentially affect the weather conditions or decide not to play in a game. But the ones that we focus on as physicians, as medical care providers, are the modifiable ones. The ones that we think we can help the individual athlete reduce their risk of sustaining an injury. And this is kind of where most of our efforts have been geared towards. So what are those risks? Well, one is decreased neuromuscular control, greater dynamic valgus loading, and fatigue without appropriate recovery time. So those are specific identifiable traits that we can identify in athletes that if we can improve through various regimens that I'll talk about right now, may reduce the risk of ACL injury. So in a more systemic way, there have been a number of what are called injury prevention programs. And these IPPs are aimed to reduce dynamic valgus loading and improve neuromuscular control. They involve a combination of plyometric, agility, strengthening exercises formulated into a program. And these programs are increasingly widespread and have been studied and shown to reduce the number of ACL injuries in leagues, in teams that adopt these IPP programs by as much as 50%. So how do we prevent ACL injuries in 2024? Well, it's a multi-pronged approach. It starts with before the season even starts. And by the start, I mean not just the first game, but really the first practice leading up to the game. So 6 weeks prior to the start of a preseason program, there is a protocol that patients and athletes can take and teams can adopt that basically work on some of the lower extremity core exercises that help stabilize the knee. Then that continues into the season with a maintenance program. In addition, many of these IPPs have written educational materials for coaches and trainers that they can really follow a script to ensure their athletes are performing the exercises appropriately. And then having sessions for athlete feedback to identify athletes that remain at risk and provide additional counseling for them. Here's just one example of one of the more well-studied IPP programs. It's called the FIFA 11 Plus. It was really designed for soccer athletes. And here's just a quick breakdown of one of those before a game. It takes only 20 minutes. It's broken into 3 parts. So for the first section, there's 8 minutes of various running exercises to warm up. Then 10 minutes of strength, plyometrics, balance exercises to really make sure that the muscles are ready for the performance. And then 2 additional minutes of running. And this is really meant to kind of supplant any pre-game warm-up. And by doing this, it shouldn't take any additional time, allows the athletes to get ready and really gets the muscles ready to ideally avoid ACL injury. So that's kind of an overview of what ACL prevention programs look like. What can we do in the sports medicine community to kind of increase these aims? Well, number one is we can increase the adoption of these IPPs across all sporting levels. While they have been adopted, there's still many programs, many leagues that don't have great IPP implementation yet. So working to improve that is an important goal. And then I think along those lines, developing sport-specific IPPs. So we want to have not necessarily an IPP that was developed for soccer, but develop those exercises that will help the lacrosse athlete before their games. In addition, we can identify preseason screening tools to find at-risk athletes. I think we've done this, for example, with hypertrophic cardiomyopathy. So there is a rubric that we could follow to identify at-risk patients or athletes for ACL injuries. And then kind of the final longer term goal is to identify and develop wearable technology that can monitor training loads. We know that a risk factor for ACL injuries is fatigue. And there are biometric signs of fatigue that if we can identify using newer technology, that might additionally help us prevent ACL injuries. So clearly there's a lot of progress that's been made, but still a lot of room for growth. So now we're going to switch gears and talk about shoulder instability. And shoulder instability is another important concept that is particularly relevant for our high school athletes. So again, let me just start with a quick video. Let's see if this will play. Want to just show you what a shoulder dislocation can look like. This is just a few years ago in a professional basketball game. Kevin Love's an athlete. And notice, this is important, notice how he's holding his arm, running off the field. It's clearly has a shoulder injury, but I can tell just based on how he's positioning his arm that that is very likely a shoulder dislocation. So shoulder instability refers to when the humeral head dislocates or moves anteriorly within the shoulder out of its socket. It typically happens with the arm out by the side and away from the body. And the most common, unlike ACLs, where it's more common in females, in shoulder instability, male contact athletes, age 16 to 20 years old. So that really is that high school boys lacrosse team that just played this weekend. Those are the highest risk athletes for sustaining a shoulder dislocation. So I want to just take a moment and walk you through what, if I were on the sidelines, if you're on the sidelines watching a team and you're concerned for a shoulder dislocation, what do we do? So I'll walk you through it. So number one is diagnosis. So typically you can diagnose this just by looking at the mechanism of injury. So if you see the athlete with their arm way away from their body, up over their head, and they have an acute pain in their shoulder, that is a high risk for dislocation. When you go to examine the athlete, you run up to them, you see them either on the field or on the sidelines. You start with the ABCs: airway, breathing, circulation. Make sure that they're stable, as we always do. Then you check a neurovascular exam. Are they having numbness, tingling? Are they having weakness in their shoulder? Typically, it's very obvious the patient will have pain right over the shoulder. Their humeral head will be palpable right in the front. So anteriorly, you'll notice that there's a gross deformity there. The patient will hold their arm right by their side in internal rotation. And just like Kevin Love was doing in that video, they're using their other arm to kind of support it because it feels like their shoulder is going to like fall off their arm. And the shoulder lacks contour. So when you see those things, you think shoulder dislocation. Now, there are two other diagnoses that I want to bring to your attention that you can also look for that might result in gross deformity. One is an AC separation, acromioclavicular joint separation. That will typically have a deformity more superiorly on the top portion of the shoulder. And that's not the dislocation we're talking about here. And the other is a clavicle fracture. And that will typically happen also more superiorly and more closer to the patient's neck. So when you're looking for deformity, you can just by inspection kind of diagnose those three different things. So how do we treat them? Well, on the field, the main goal is to try to reduce the shoulder as quickly as possible. Delay makes the reduction more difficult. You do not need to get x-rays prior to attempting a reduction. If you think that the shoulder is dislocated, you may perform a closed reduction maneuver without needing to get x-rays first. So step one, if you suspect a dislocation, you want to attempt to reduce it. The first thing you got to do is get the athlete calm. Explain what you think is going on. Explain the next steps that will allow them to kind of relax, and that will help you with your reduction. So there are many maneuvers for reducing a shoulder. They all can work. You should have a couple of them in your tool bag, right on the field or right on the sideline. What I typically do is have the patient either resting, either sitting up, or if they can't, they're laying down. I pull gradual distal traction on the arm and then gradually bring their arm into abduction and a little bit of external rotation, sort of what you see the trainer or the medical staff member doing in this picture. Just by doing that, typically that's enough, and you do it slowly, and the muscles will relax in a specific way and the shoulder will reduce. What's important is not just the reduction, but what you do after the reduction. So number one, you want to assess the axillary nerve. So you just palpate, just take your fingers and feel the side of the shoulder, see if they have any nerve numbness or tingling. Make sure that they can grab your hand with their wrist, with their hand. Make sure their grip strength is intact. You can put the patient in a sling. You place a bag of ice over the shoulder, and they should sit out the remainder of the game. It's also important, even if you're very confident that the reduction was successful, I always counsel medical providers to have the patient get post-reduction x-rays that night. It's not an emergency, but if they want to, they can hang out, watch the rest of the game as long as their pain is controlled, but they should get x-rays to make sure that the shoulder is reduced, as well as to make sure that there's no concomitant injury such as a fracture that may have happened at the time of injury, or reduction can sometimes cause a fracture as well. So it's important to diagnose those things early. So treating the first-time dislocator. This is, I don't want to spend too much time on this, gets more into the surgical side, but what I can tell you is that there are many patients who, if they're in the season and they don't have bone loss, this is their first time dislocating, they can be treated non-operatively. And so what does that look like? Well, number one, it's a restriction of activities to start, so they won't be playing their sport for a period of time. We'll get them into physical therapy, and physical therapy is really aimed at regaining some of the strength, helping make sure that the patient restores their flexibility. Oftentimes after a dislocation, the shoulder swells up, the patient's apprehensive, so there's a tendency for the patient to develop stiffness. So physical therapy is really aimed at remobilizing the shoulder. While I only keep patients in a sling really for a couple of days after this sort of dislocation, then I really want them to get it moving again. So bracing in a certain position has been studied and shown not to really provide much benefit. But a solely brace, as depicted in this picture, can be helpful for certain athletes, particularly ones who don't require a lot of overhead activity. So think like the middle linebacker, defensive lineman. Those athletes are perfect for these solely braces. A baseball pitcher, much less able to tolerate this. So when can a patient go back after they've sustained a dislocation? Well, there's certain criteria that need to be met. Number one, they need full range of motion, full rotator cuff strength, and no apprehension on physical exam. So that typically can take 3 to 6 weeks, although there are studies that say some people get back sooner. I tend not to rush patients, and I think the goal is you set a lower expectation, and if they return more quickly, then the patient is a little bit more optimistic there. But it's important to note that counseling the athlete is critical following a shoulder dislocation. There is an extremely high rate of recurrence. So 17-year-old male contact athletes, just like the athletes that were playing in the Long Island, in the New York State tournament this past weekend, 90% chance of recurrent dislocation. And there's a cost to each recurrence. There's other injuries that can happen in the shoulder. You can get bone loss from the friction of the bones rubbing up against one another. And just like with ACL injuries, there's a higher risk of long-term arthritis. And so for those reasons, the pendulum really has swung more towards being more aggressive with surgery in this at-risk group. We have a lot of tools that we won't get into in this webinar, such as a Latarjet, remplissage, a lot of new surgical developments that we can implement to help make those surgeries more successful. And what we find is treating these patients earlier may prevent longer-term issues or recurrent dislocations. So with that, that's my time. I'd like to thank everyone for their attention today. I appreciate you listening either live or on the webinar. And I look forward to hearing these excellent talks coming up by my colleagues here at HSS. Thank you.
Before we move on to Dr. Wyss, I just want to ask if anyone has any questions for Dr. Brusalis. No specific questions?
I have a question, doctor. You mentioned the wearable technology. Now, do you see that for prevention, and do you believe that they can get down to the high school level? I know that's working in the pro level and the college level, but do you see a future in the high school level?
Yeah, that's a great question. I definitely do. I think that in general, technology starts out more expensive, less accessible, and over time it becomes more financially feasible and more widely available. And I think, the first laptop computers were probably, there's, a handful of them in the government. Now everyone has one. And I think that technology will eventually get to be more widespread. It usually starts just like you said, it starts in the pro level athletes. It shows that there's some success. And then eventually companies realize that, to get the market share that they'd like, they have to make it more affordable, and it gets out to more athletes. So I think it's a matter of when, not if.
Great. Thank you, sir.
And yeah, wearable technology would be pretty interesting. It'll give a lot of data. When we get that on the professional level, it's interesting. And then what you do with the data is a whole nother topic. So a lot of challenges there. So I'm going to discuss some somewhat less exciting conditions like lower back pain, hip groin injuries. I'll touch on the hamstring as well. Unlike what Dr. Brusalis just talked about with the ACL, there's tons of effort and time and money that has been spent on trying to prevent that condition. And so there's a lot of good data there. And in these areas I'm going to discuss, there's a little bit in terms of prevention. So I kind of guided my talk based on the information available. These are just some of the hats I wear, no relevant disclosures. And there's also, as I was preparing for this talk, there's not a lot of great high school related injury data. There's a lot of good stuff across the board from places like NCAA and CDC. We could definitely use better data for our high school athletes. But in terms of low back injury in high school sports, this does happen, and everybody pretty much knows about lower back pain, but it becomes far more common as we get older. If we look at this data, it doesn't even here include the adolescent, but when we're 18, about 25% or a little more will get it. By the time we're 65 or older, 50% almost. And I find that, the 10 to 20% range in those adolescents is fair for both athletes and non-athletes alike. So it is still common enough. It is not a pulled muscle. It's not growing pains. That's the biggest mistake I see. I get referrals for an athlete who's been experiencing several months or even sometimes a year or two of back pain and being treated as a muscle pain, or it was just growing pain. And what it tends to be in about half the cases is a bony injury, similar to a stress fracture you would have in other parts of the body, like the tibia, that is very commonly recognized in running athletes. And similar to something like Osgood-Schlatter's in the knee when we're talking about a ACL injury. So we recognize bony injuries certain places in the body. We don't recognize it as well at the spine, probably because it's deep, because you have to see through all the muscles that are there to kind of get a sense of where this pain's maybe coming from. So people present with a lot of muscular symptoms, but after probably 10,001 MRI reviews and counting, I don't see muscle strains like I do in the thigh or the lower leg. I see bony injuries. And so basically what we're talking about, if we do just a rough review of the spine, each vertebrae has a anterior front component, that's the vertebral body, and then a ring in the back. And on the back side of it, there's an area called the pars interarticularis, which means the bridge between joints. So it's in between the set joints, and that's where the developing spine is at most risk for injury, stress reaction, stress fractures, or what we call a lysis when it actually breaks. And now the ring is disconnected on the backside, so you can get forward slippage, spondy, spine, lysis, slippage. And again, on many times we get x-rays that are relatively unremarkable. If we're really suspicious of a bony injury, we go on to get an MRI and we just see increased signal in the bone. And sometimes we see the actual stress fracture line. Our radiologists are involved in some nice research in this area to try to see in these younger athletes if we can turn an MRI into a CT scan, and they're making really nice progress. So we can get that 2-for-1 data without all the ionizing radiation. And this down here shows a break in the region of the pars, what we call a spondylolysis. This is evidence of it on x-ray. These are bone scans. I put that on for historical purposes. We really don't need those anymore. I basically get an x-ray, and then if it's negative and I'm still suspicious for a bony injury, I'll get an MRI. As we know, adolescents are different in every different way. As I have a 15-year-old and a daughter who's 20. I know adolescents are different, but it's proven through study. This is an old study that was done, but they took basically 100 people who presented to a clinic with lower back pain, and they separated the adolescents and the adults, and they found that 47% of the adolescents with back pain were presenting with stress fractures, and 48% of the adults were presenting with disc problems. So that's basically how it breaks down. Once we're skeletally mature, about half of our trouble comes from that disc, that shock absorber between there. Before we're skeletally mature, these are bony injuries. So really the early recognition and detection of these injuries are key. And the reason why they're so important is because if we don't recognize a injury that's somewhere between these two stages before we actually get a break and a lysis there, it can progress to a spondylolisthesis, and that can cause some ongoing impairment, decreased sports performance, but even long-term contribute to an earlier onset of stenosis and disability in the spine. So prevention of lower back pain. So I'm a physiatrist. My specialty is physical medicine rehabilitation. Many of my colleagues treat lower back injuries, and some of us focus on it in a athletic population. The late Scott Nadler did a lot of work in the NCAA athletes, and he found that there were a bunch of modifiable risk factors. And, we would love to say that just strengthen your core and you'll prevent lower back pain, but it doesn't seem to be as simple as that. It's not just stretch a tight hamstring. It certainly may be associated with these bony injuries, but it's not the whole picture. Hip and core, hip and the glutes functioning well did pan out as a better potential preventative tool in some of his research. And I do find that. I find that a lot of athletes that I see, young athletes, they lack good single leg control. They lack good available hip mobility. And I think and hamstrings being tight on top of that. So a lot of the stress and load dumps into the lumbar spine when they're not using their hips well enough. So hips functioning better, probably decrease lower limb injuries around the knee, like ACL, probably also help us to prevent some lower back pain. And basically, if you're wondering who's the greatest risk for any of these orthopedic injuries, really anyone who has a prior history of injury in that area has a higher risk in the future. That's been proven most at the ankle, but the other body parts as well. So next up, the hip. And we have a lot of potential injuries that can occur around both the pelvis and the hip joint at the ball and socket. People spend a lot of time talking about impingement, pinching at the hip, and labral tears that occur, and that's certainly part of it. That's a whole lecture in itself, so I'm not going to get too deep on that. But realize in young athletes, you can also get bony injuries, so not everything's a muscle pull. There are growth plates around the pelvis, such as at the iliac crest, such as at the sit bone, the ischial tuberosity. And so not everybody pulls a hip flexor or pulls a hamstring. Some of these young athletes, the bone can be injured in the process. So when we look at the hip and groin injuries, older studies say about 5 to 6% of injuries that are presenting. That number's risen. I think it's risen as awareness of pre-arthritic hip conditions have increased, as there are more of colleagues in orthopedic surgery who specialize in the hip, and that's increased that number. So there was probably more of it out there, but now there's just better awareness of it. Couple injuries I see a lot in the young athlete and the collegiate athlete are groin pulls or adductor strains and hamstring injuries. And of the muscle injuries around the hip and thigh, the hamstring's one of the most troubling to deal with because it takes a while to get that recovery. Sometimes they don't have a full recovery, and then there's a high likelihood of recurrence, and that becomes really challenging on all level of sports. So again, like I mentioned, for the lumbar spine, the early recognition and detection, I think, is key, whether we're talking about muscle injuries around the groin and the thigh, or whether we're talking about maybe a kid who's really talented athlete, a middle schooler who's been pulled up to JV or varsity, or your 9th and 10th graders. That's the group that I do see. They come in with a presumed diagnosis of a hamstring injury, and they've actually pulled off part of their ischial tuberosity, and it's different level of injury, needs a different level of rest, not as aggressive rehabilitation at first because the bone has to heal. So prevention of hip injuries in athletes. So there is better data here. Dr. Brusalis showed the FIFA 11 plus before, and that was in reference to preventing ACL injuries. There's also some evidence that it can prevent other lower limb injuries, including hamstring strains. There's the classic Nordic hamstring program, which you can do with a teammate, a coach, an athletic trainer, and that can be used preseason and then maintained through the season to maintain good eccentric control and strength of the hamstring muscle. And in groin pulls or adductor strains in other sports, it's probably best to put your attention towards those who have had a prior injury and preventing it, and make sure they maintain really good strength of the adductors through the season. That's been shown to reduce injury in the group that has had prior adductor strains. So in summary, I know I highlighted the bone a lot here, but that's because in the lower back and pelvic area, I just find it's underappreciated, underrecognized, late to get the accurate diagnosis that really can make a difference in the short and long term for these athletes. That's why I really focused on that. Again, there's good secondary prevention strategies for the lower back, but is not proof that we can prevent lumbar spine injuries from occurring. They're just so common. In the hip and groin injury area, I think since the hamstring strains end up being really challenging and frequently recur, we need a little more attention and a little more focus on preventing those from initially happening, and especially getting on it when you have athletes who have had those injuries before. And that's the talk there.
Thanks, Dr. Wyss. Does anyone have any questions for Dr. Wyss before we move forward?
I can ask a question. Dr. Wyss, great talk. That was a really outstanding overview of a lot of like complex issues there. But
I was a little jealous not to have cool videos like you. You know, I'd have somebody on the sideline holding their back.
I know.
You have next level video. So great job.
A little harder to replicate, but yeah, great talk. My question is, I kind of think I related to what I see a lot, and for shoulder pathology, a lot of patients come in with neck pain and shoulder pain, and there's kind of an overlap. I wonder, in your practice and the athletes that you see all the time, do you see overlap where someone might have a lumbar strain and it either leads to, or they have a concomitant injury in the hip because they're compensating? And is that something you see? And what can you tell patients? Like, I always tell patients, like, at least with the shoulder and neck, that strengthening one can help avoid issues and injuries in the other area. Is that something that you come across or you think about with your patients?
Yeah, 100%. And I think you're right. I think if you're compensating for a limitation, it may not even be pain. It may just be a limitation or a weakness. It causes you to kind of dump into the other area, whatever that is. And since I treat a lot of hip and spine conditions, there's tremendous overlap. In the young athlete, we've done a little research within our department and found that there's probably a little higher incidence of FAI at the hip, so impingement at the hip, in those who are having then lumbar spine stress fractures. But that hasn't been proven on a large enough level, but I certainly see it. So that becomes a big part of the rehabilitation approach to it. It's like, okay, yes, you have lower back pain, but there's another part of your body you have to get functioning better. And I think athletic trainers, physical therapists are great at recognizing that and rehabilitating it properly. And we need to do a really good job of carrying that message through.
So I'm going to be talking, we're going to finish at the bottom. I'm going to talk about prevention of foot and ankle injuries. Here are some of my disclosures. So, what I really want to talk about is identifying some risk factors and then some meaningful interventions that, coaches and trainers can use at their disposal. So foot and ankle top three for me is Achilles. So Achilles injuries, both Achilles tendon tears and tendinitis, ankle sprains, and then fifth metatarsal fractures, which are breaks in the foot, usually with cutting type sports. So let's talk about Achilles injuries. So very often what will happen is that someone will come out of a back pedal, like let's say a cornerback, or in this case, a basketball player, and they'll feel a pop or a snap in the back of their ankle. They'll say they feel like they were shot or that someone hit them with a hammer in the back of their leg. And this is almost pathognomonic. Like, you hear that story and you can almost guarantee that they popped their Achilles. In the NBA, you hear about it, but the risk is overall really low. It's less than 1% in both the NBA and the NFL. But Achilles tendinopathy or Achilles tendinitis was responsible for about 2% of injuries across the board. And again, these are more common in jumping type sports, again, like basketball. So what are your risk factors? So the risk of Achilles rupture increases with age, weight, and overuse. So tightness in the calf and the hamstring may increase risk, but there's a lack of data. People who are on steroids or certain antibiotics may increase the risk. And the most troubling thing about Achilles ruptures is that almost 80% of patients never have pain there before. So in terms of trying to predict who's going to rupture their Achilles, it's still a little bit of an enigma. For high school athletes, it's actually more common in gymnasts. For basketball, football, those types of sports, it's really more common in the middle-aged athlete. So as you get older in your years, and certainly your recreational warriors, and certainly pickleball has actually kept me in business. But what I would tell you is that for most people, they never have symptoms there before, so it can be a hard thing to predict. If you rupture one side, the question is, well, am I at risk for injuring the other sides? And the answer is, yeah, but not very high. It's been reported as high as 6%. In our series, it was less than 1%. So, basically, if you rupture your Achilles, there's a 99% or so chance you don't rupture the other side. And once you fix it, the risk is very low as well. Moving on to ankle sprains. Ankle sprains are really common in the NBA. The one-season injury risk was about 25%. So if you play basketball, it's kind of an occupational hazard. It makes up 17% of all game-related injuries. 44% resulted in missed games with a median of 2 games missed. It's very common in military populations as well. So what are the risk factors for whether or not you're going to sprain your ankle? So one risk factor is your alignment. If people have like a very high arch foot, or if you see the foot type in the top right corner, that can be a risk factor. Generalized ligamentous laxity, I kind of refer to these kids as kind of loose gooses, like people who can like hyperextend their elbows and hands. Taller, heavier patients can also get this. But the biggest are the jumping sports, so basketball, volleyball, cheerleading, and some other sports as well. And there's some other intrinsic foot conditions that can also put you at a slightly higher risk. This was kind of mentioned before by some of the others. Your biggest risk factor for whether or not you have an ankle sprain is, did you have a prior ankle sprain? And this is true for spraining the same ankle, but it's also true for spraining your other ankle as well. So your biggest risk is whether or not you've had a prior ankle sprain. Moving on to the fifth metatarsal. Again, not that common. The overall risk for having a fifth metatarsal fracture is less than 1%. But as stress fractures go, it's a very common stress fracture, again, particularly in basketball and football players. And it is responsible for a good portion of games that are missed. The risk among NBA players or basketball players, there are some things about the foot type that actually put people at risk. If you see someone's foot and they have this real kind of prominence at the base of their foot, what that means is that that area is being loaded more than like the average person, and they may be at a slightly higher risk of having a stress fracture or stress reaction because of that. Also, like from just a technical standpoint, if they have a long, straight fifth metatarsal and an adducted forefoot, which means their foot is kind of curved, they're also at higher risk for having these types of fractures. Kind of similarly, if you break one side, you're at a slightly higher risk for breaking the other side. But it's still overall pretty small. In our series, is only about 3%. So once you have one of these and it heals, usually you can go on to finish your career without a problem. But there are some people that have a higher propensity to get these types of injuries. Again, particularly in like cutting type sports. So what's my role in injury prediction? Actually, we just went over our draft for the basketball last night. And, sometimes I feel like the picture on the left, which is like I'm an actuary doing like a risk analysis like an insurance company would. But for the most part, I feel like the picture on the right, which is I'm just trying to guess and look into my crystal ball to see what's going to happen. So I think that injury prevention is a great area for research, and certainly something we need to study more and learn more about. We know some things, but still a lot of it is unknown. So I think that I'm going to get now to the takeaway parts that I have for the group, which is, given these factors, how can we lower the risk of having some of these injuries so that, we can keep our athletes on the field? Well, I think you can break it into two major buckets, which are their extrinsic targets, such as what shoes people wear, the surfaces they play on, orthotics, bracing, and then this concept of load management, which I'll talk to. And then there are more intrinsic targets like nutrition and neuromuscular training, which I'm going to talk about. So let's quickly talk about turf and grass. So this is a pet project of mine that I had done research years ago, but it's always been an interest of mine. So the new generation turfs has gotten better. Basically, you started with like a carpet, which is like the AstroTurf on the bottom left. Then they put in some threads and basically grass-like filaments, and now they added infill to kind of simulate dirt, which is crumb rubber. And the whole goal is to try to replicate grass, which is both having the grass and the dirt underneath. Okay, and people have played with the infill, so you can start with nothing, and then now they have all these various types of infills. All these things do is they change the material properties of what you play on, and ultimately change how it feels to play on and how quote unquote sticky the surface is. And then the next question is, what shoes do you put on it? And do you wear sneakers? Do you wear cleats? And do you wear the studs? And the reality is that all of these different shoe types have different biomechanical properties and put you at different levels of risk. As a general rule, when conditions are slipperier, meaning it's like wet or surfaces aren't good, you want a thicker cleat. But as a general rule, you also want the cleats to give a little bit. So you want less like the picture on the bottom right, which is almost these like wedges, and more conical cleats. So that gives it a little bit of give. So you're less likely to get quote unquote caught in the turf. When you change direction on grass versus turf, here's the biggest difference. In grass, the surface will give a little bit. So there's some play in the system, both in translation and in rotation. Whereas in the artificial surfaces, there's essentially less give. So a lot of people like artificial surfaces because they feel like they're faster or their performance is better, which is true because of the traction. The downside is that it doesn't give as much, and you're at a slightly higher risk of injury. So specifically, this was one of the better studies that was done. This was done in the NFL. So the ankle sprain rate was about 22% greater on turf than grass, with eversion sprains about 30% more likely. And then overall, there was a 16% increase in lower extremity injuries, and particularly like non-contact ACL injuries and high ankle sprains. And again, this is because there's more torque with the artificial surfaces. So the trend was especially pronounced for these non-contact injuries. And this is one of the best studies that's out there on it. We did a study, a biomechanics study, looking at rotation forces and traction, which lead to increased injury. And what we found was that natural grass was basically your safest. The strain in your ACL, when we did kind of a cadaver project, went up about 30 to 40% on the artificial kind of field turf surfaces. And then when we went to like an AstroTurf, it was up 80%. So basically it's less strain on your joints when you do the grass. So I was part of a committee looking at the MetLife Stadium and picking out their turf. And it was an interesting conversation because a lot of high schools go to these field turfs, and the reason is that they're cheaper and they're easier to maintain. So there's an initial higher increased cost, but the maintenance costs are very low, which is grass is really, the startup cost isn't as big, but the maintenance is very high. And if you play in the northeastern climate, or in case of MetLife Stadium, where there's tractor pulls and concerts, the grass can get beat up. And playing on bad surfaces does increase your risk of injury. So in the NFL, about half the stadiums are turf, but over 90% of players responded that playing on artificial turf would shorten their careers. And I don't know if any of you guys follow the World Cup, what's been going on, but the women historically were playing on turf. This was a few years ago. I was actually asked to be an expert witness. And they sued the FIFA to try to get it played on grass. And actually this year, when the World Cup comes, they're taking out the field turf at MetLife Stadium and putting grass because FIFA demanded that all the guys play on grass. And basically all the studies show, there's a bunch of really good studies that show that there is an increased injury risk on the turf. So why do they still do it? Again, because it's cheaper. The differences may be statistically significant, but one can argue clinically how much of an increased risk is worth it. There's also, it's a hard thing to study because there's a lot of variables, including the shoe, the temperature, the moisture, the variations in foot position and sports and levels. And again, this is what the NFL does. They use a machine to actually test the shoes and the surfaces to get these different things. And different shoes can be evaluated, so all shoes aren't the same. What I would tell you guys as coaches and trainers is that a stiffer shoe is actually a little bit more protective. A lot of the players want very flexible, kind of lightweight shoes. And while they may be lighter and may in theory increase your speed, they also increase your risk of injury. So a stiffer shoe is a little bit better. Every year, the NFL gives out these traction scores to the teams to let them know, so to help players make a decision. One other thing I want to let you guys know about is minimalist shoe wear. So there are cases of metatarsal stress fractures. So just be careful. Like, I do think shoes matter. There's certainly a lot of variability, but this high idea of like, oh, I want to just run barefoot or run with no shoes, just know that you're increasing, you may be getting your foot stronger, but you may also be increasing your risk of injury. And you can get these stress fractures, and those can obviously set your patients back. So my advice is when you're training, you wear shoes like this, which have, they're a little bit heavier, but they also have a very thick kind of almost foam cushion sole. And what that does is it basically takes some of the stress out of the system. So it lowers your risk of injury. And in theory, I offer this to all my patients. It decreases some of the stresses on the foot. The other things, orthotics can be very helpful. Orthotics increase the risk of stress fractures, but not necessarily soft tissue injuries. We did a study looking on cadavers, and orthotics were found to reduce the strain in the metatarsal. So again, putting you at a slightly higher risk of these stress fractures. Again, what's interesting is when you kind of the two competing views of performance versus protection. This is a carbon, or this in case it's a steel plate that sometimes we'll put in the shoe. If the shoe is super flexible like this, again, you're in theory at risk of injury, specifically when it regards to turf toe. So turf toe is one of those injuries where your toe bends back or gets jammed in the turf and you hyperextend the big toe. Well, there are studies that show if you protect the toe going past about 56 degrees, you never get that injury. So if you protect the shoe and make it a little bit stiffer, they won't have that injury. But a lot of players, they want that flexibility. So again, you're balancing the performance versus the protection aspect. And finally, I want to talk about bracing. So a lot of people feel like when you brace a patient, you're actually overprotecting them, or people are using that as a crutch. The only thing braces do is they actually lower your risk of having another ankle sprain. You don't get weaker. You don't are worse off longer term. You're just lowering your risk for an ankle sprain. So taping and bracing are actually important. So for all of our players or professional athletes, you have a prior history of a sprain, you get taped and/or braces. You just have to be careful with the tape. A lot of times it can be loosened get loose by halftime. So we'll have people retape or re-brace at halftime. And neuromuscular strain. So if you have neuromuscular training, which is if you have patients do little exercises to improve their mechanics and improve their strength, that can also lower the risk of ankle sprains. For sports like basketball, super. A couple other intrinsic things now, nutrition and vitamin D. So vitamin D is important. The results vary. The biggest thing is eating a balanced diet and avoiding a sustained calorie deficit are the most important things for bone health. So there was a pronounced risk of stress fracture with undernutrition. This is especially true for female athletes, specifically those who may be on the lower BMI side or anorexic athletes where they're not getting enough calories. If you're in that position, you're at a higher risk of stress fracture. So I think that vitamin D is important. Like I said, lower levels of vitamin D can be associated with stress fractures. So make sure people are getting their milks and yogurts, things that have calcium and vitamin D. And if they're not, if they're vegan, make sure they're getting it through other methods. So is it causation or correlation? So as I tried to go through a bunch of these risk factors, but the biggest risk factors for these injuries are, do you play sports? So when you play high level sports and you have a bunch of loads on the feet and the ankles, you do put yourself at higher risk. So load management is a term that's getting thrown around now, especially in the NBA. And, there have been talks about, like, is there increased risk of injury with back-to-backs? And each rest day between games can lower overall injury rates. That being said, you still need to load things so that the tendons and muscles can build resilience. So what I would tell you in terms of, like, whether, when you guys are thinking whether or not to rest people, there's like a sweet spot where your muscles, your tendons, your joints need to experience some load so they can build strength and resilience, but you don't want to go over the edge to where they develop a stress injury. And we're still working on the mechanics of where that is. But, like, for example, like pitchers is an easy example where you don't, pitch back-to-back games, full games, right? Because you're going to throw out your shoulder or your elbow. You want a certain amount of rest, but you don't want all rest, because if you just rest, then you're going to have an injury because the muscles and tendons aren't appropriately built up. So what's now and what's in store? I think it's possible to some degree to manage load, wear good shoes, braces, or orthotics, and in the future the data will set us free. And we're doing more studies to start to stratify risk, see who's at a higher risk factor based on their pre-injury physicals. My practical advice to the group out there is make sure everybody warms up properly, stretches, and stays hydrated. You ease into intense training, so you don't come out day one and just go kind of all out. You kind of build to that. Get proper equipment. I'm a big grass fan, so use grass whenever possible, even if it's just intermittent. And again, the kind of goal is to hit the sweet spot between loading to build strength and avoiding overuse injuries by listening to patients and their bodies and how to keep them on the field. So train smarter, not just harder. Thank you.
Amazing. Thank you, Dr. Drakos. Does anyone have any questions for Dr. Drakos? Or now that you've heard all three of our speakers, any questions for any of our speakers?
I have a question for you, Dr. Drakos. For load management, that's such a term that is being thrown around over the last couple of years. But for high school athletes, the schedules are condensed. So how do you balance, or is there advice that you balance the load management as opposed to letting the kids play the entire season, because your window is so short to get the college recruiters and so forth? So how is that balance? What is your recommendation?
Sure. I think that's a great question. And, I'm seeing the people that get hurt, right? So that's like a bias that I have. But one of the first things I'll do with these overuse injuries, I'll say, tell me your schedule, write it on the board, or like, and very often these athletes are playing on high school teams, club teams, rec teams. And so for me, I'm like, listen, like I'm a firm believer in cross training. I'm a firm believer, and specifically at a young age, not, becoming super focused and then kind of focusing maybe on one sport later, because giving your body time to rest. Now, to your point in terms of college, I think in that demographic, once you get to high school, I'm more okay with you focusing and subspecializing on a sport. But there's plenty of studies that show if you subspecialize early on, you're probably putting someone at a higher risk for these types of injuries. That would be point number one. Two is when you're in the thick of it, like let's say you have a high school athlete and you're saying like, okay, do I do load management? It's like, again, I kind of say like, listen, do one team or at tops two teams. But if both teams have practices, you can't leave, you need to have rest days in there somehow, or at least light days. Like, so for instance, if people are like lifting or working out, you do have heavy workout days and then low workout days, right? What's amazing is that a lot of kids are very resilient. And, I kind of give kids a little bit of a pass if they've never had an injury. Meaning, like, if you just ask me on the street, like, oh, my kid's doing X, Y, and Z, I may say, like, listen, doing 3 teams is too much in my opinion, or like exercising every day. But, if the kid doesn't get hurt, there are plenty of kids that can do that, right? But once you've demonstrated you've had an injury, now I'm going to be like, listen, parents, like you need to like cut it back a little bit because you're going to burn this kid out. And so for load management, when dealing with high school players as well, if you've had an injury and coming back from an injury, I'll talk to the trainers and coach. I'm like, listen, do you want them there for the games or you want them there for practice, right? And I think that most coaches have evolved to understand that, listen, the old school philosophy of you don't practice, you don't play, I think is a little bit outdated. And listen, every kid's a little bit different. So if a kid's recovering from an injury, I don't think you should be doing like, gassers every day, maybe like the rest of the team does. So what I would tell you is you can individualize the approach, okay? Number two, get a good injury history. If they have a history of injuries, then maybe you're not going to do all the same reps that, every kid does, right? And then you have a real heart-to-heart with the parents and the kid, like, listen, we get that you love basketball, soccer, whatever, but, your body does need time to recover. I think most of the science, I think these guys will agree, show that recovery is just as important a part of performance as, the actual training part. So, you're trying to hit that sweet spot, and, everybody has kind of a different sweet spot, I would say.
Thank you. I appreciate that.
Oh, that was great answer, Dr. Drakos. I would just add to that your recovery tool is sleep, and these kids don't sleep enough for their age.
It's because of the electronic crack that's the phones.
Amazing. Thank you all so much. Thank you for attending. Thank you, Dr. Brusalis, Dr. Wyss, and Dr. Drakos.